Great. So good afternoon. So I'm extremely privileged to be presenting in this great session. So I'm going to be talking about something slightly different with respect to endothelial keratoplasty, and I'll show you why we do this surgical procedure. So it's called femtosecond assisted DMEK or FAD. So these are my disclosures. So of course all of you will know the Mehta surgery has really become the gold standard procedure for choice for corneal transplantation, whether this is respecting to changing the endothelium in the form of EK, DMEK or DSEK, or stromal disease, where it's one of the AIOC techniques. But you know, we still need to do penetrating keratoplasty. Only about 14% of my cases are penetrating keratoplasties these days. And sometimes it can be quite difficult to determine which is the correct kind of procedure to do, especially if you do a lot of EK surgery. So I'll show you this case to start with. 70-year-old Chinese lady. So Professor Rao, most of my patients are Chinese. 72-year-old, right eye reduced visual acuity from herpes simplex with a recurrence. Right eye pseudophakic, and you can see the herpes simplex virus on the stroma. Basically, it increased and started affecting her vision. She was on oral prophylaxis, and her vision had dropped basically to count fingers. If you look at her ASOCT, you can see there's a deep stromal scar, which you can see obviously on the slit lamp, and she has peripheral vascularization, so we know there's a high risk of penetrating keratoplasty, and it's herpes simplex as well. So of course, even higher risk of doing a full thickness PK as well. And I felt that there was enough room there to do basically a good dog surgery. But if you look a little bit more closely on the ASOCT, you'll see these little ridges there on the endothelium, and this really is something to be careful of when you're doing herpes simplex cases, because this is actually a fold in Descemet's membrane. I'll show you this, how it can have an effect directly on the surgery. So we went ahead first with a manual dissection technique to basically do the dog surgery. So this is the standard way we will normally do dog if we're not going to go basically to get a big bubble in these small high risk cases. So the idea is to do a deep manual dissection as deep as possible. And you can see with the surgery, and I'll show you the result on the right-hand side as we get deeper, you'll see that as I got deeper down to within 50 microns of Descemet's membrane, you can see I saw these ridges and folds in Descemet. And typically you do see this with herpes simplex virus sometimes, where you get this ridging basically on the Descemet. And this is a complete fold in the stroma, and there'll be some defunctive endothelial cells as well there. If you look at this in a little bit more detail, you can see it on the slit lamp, and this is the post-operative AIOC. Her vision improved from count fingers up to 645. You can see the folds now coming on the video as I'm getting closer with the dissection. You do have to be careful. You can easily rupture these folds when you're doing the surgery as well. So we were left with the decision basically of either leaving it. She was 645. She had minimal improvement with the rigid gas pulmonary contact lens. Some people said, well, you could do a DMEK, which I'll show you why you can't do a DMEK, or of course you could do a PK, but then of course you'd had undergone 2 surgeries. So the reason why you can't do a DMEK in this situation is that if you look at basically the OCT in a bit more detail over here post-op, what you'll see is that you'll see the Descemet's membrane, and if you just do a DMEK, all you're going to be doing is removing the Descemet's membrane and leaving that stromal scarring behind. So what you want to do is basically do a femto-assisted DMEK, and the way we basically do is that we cut the inside, from the inside of the anterior chamber, into the stromal tissue using a femtosecond laser. And for the lasers to do this, I use the liquid penetrating keratoplasty module on the Z8 femtosecond laser. So this is the surgery. So basically after it's basically marked, you dock with a liquid applanating system on the Z8 femtosecond laser. This allows you to basically cut from the posterior surface, and you can individualize and set your cut 30 degrees all the way around the graft, so you know exactly how high you're cutting up from the posterior side into basically the stromal tissue. So it's truly real-time adjustment of the vertical cut. You then simply basically fire the femtosecond laser once you've basically gone round on the OCT. So you can check every 30 degrees round, so you're ready, then you fire the laser, so it's firing from the posterior side upwards, and you can vary the height and customize it depending on how you basically want. So you can see the bubbles where the laser's been fired, then you go around with the Sinski hook, and you simply basically just detach the area of where the laser is cut. Now, of course, where there's stitches left behind, you find a little bit of adhesion, sometimes you have to use a little bit of a forceps, and once you remove the tissue from the inside area, you're going to basically replace this, and typically the way I replace this now is you can see the tissue over there with the scarred area has basically been removed, and typically I replace this with the standard DMEK tissue, and of course I do an endo-in technique, and you have much more control on the graft. And of course the tricky thing here is you need to fit the graft into that area that you've created with the femtosecond laser in 3 dimensions. So you do need to have good control of the graft to adjust it directly into position itself. So you can see the adjustments over here. And once I'm happy with the position, with the forceps, then simply I'll put a bubble inside the anterior chamber. There we go. And then basically the rest of the surgery is normal, where your tamponade basically is normal. So this is the first case I actually did day one post-op. You can see a small, basically, detachment inferiorly. We went back and rebubbled her with SO6, and basically got a good improvement in visual acuity outcomes. So she went from 645 to 69 with a pretty good cell count basically at 1 year. This is the second case, a case that was done by a colleague of mine who basically had previous fungal keratitis with a scar. They did basically a dog procedure, then somebody did a cataract surgery after this. This was during COVID. Vision got up at 624, and then they were sent to me a year later afterwards with a reduction in visual acuity. So I went back and did the same procedure as I showed you on the previous case, and the patient got a pretty good outcome with respect to visual acuity, as also basically a cell count as well. So I'll show you a slightly more complicated case now. This is a 7-year-old girl with diagnosis of pediatric blepharokeratitis related to DMEK. She was on usual topical therapy, and she was having recurrent flares of her PBK. We lost her to follow-up for almost basically 3 or 4 years. She then represented 3 years later with a reduction of visual acuity in the right eye. You can see that central basically scarring with basically thinning. She then disappeared again. She was seen in private clinic for about 2 years. Her vision had dropped basically to count fingers, and she came to my clinic like this with a hole basically in her eye where she perforated over the area of basically thinning. So I did a manual basically dog for her, and you'll see there was a little bit of basically a Descemet's rupture basically during the surgery. So I rebubbled and repaired basically the dog. As it basically settled down, we took out the stitches. She got to basically about 636. And again, we lost her to follow-up for 2 years, and she pitched up back to my clinic looking like she did on the right-hand side. So again, you'll see the deep central scarring on the surface there. So I took her back, and then I did a repeat dog for her at that time. This is what she was like at day one post-op. You'll see why on the video where the central perforation basically opened. Then I went back to basically seal that again. And this is basically how she ended up, about 636. But you can see that scarring basically on the posterior side. So the plan was then for her to undergo a repeat Femto DMEK procedure after we basically stabilized the ocular surface. And I'll show you this when you're doing repeat dogs. Of course, in previous perforation eyes, they can be quite challenging, especially if they've got a large hole over here itself. But these are still doable, and it's still worthwhile doing a dog in this situation as opposed to doing a penetrating keratoplasty, especially in such a young child. So as we repeated the central area, you'll see why there was basically a double anterior chamber on day one. So as I basically peel off with the old scar, you can see the leak from over there, and you'll see a hole basically where I tried to seal this afterwards. And generally, you can basically be able to tamponade this to get this to seal. So we went back to do a repeat, basically Femto dog for her. So this is the surgery. So she's phakic, of course. She's only, I think, 15 now. So went back. Surgery's exactly the same. So again, you peel away basically the area that's been cut. The bubbles will tell you where the margin of the laser basically cut is around the surface, and you're using a reverse Sinski and a pair of forceps, you can gently peel away the separation. Sometimes if the margin between the graft host junction and the Femto cut is very close, you can get some separation there, like you can see that in the top part over here itself. So I'll push away that area there to keep that away and keep it intact. So once the graft is basically out, this is basically then ready to go. Obviously, where this area of haze, if the laser doesn't cut, as well as the area where it's basically clear. And then we basically will put the DMEK in. So this is DMEK in a phakic situation in the standard same way. And the advantage of using an endo-in procedure is that you don't have to worry basically about channeling the anterior chamber. So the graft basically will come in the standard way. And then this is basically opened up, and like I said, you've got to try to get it within that gap there that you've created basically within the femtosecond laser. So in the interest of time, I'll just show you the outcome. So this is her basically 2017. This is after her basically second dog, down below over here. So the first dog, and then basically the second dog, and this is how she is now basically 4 years basically post-op. So pretty good outcome for her. So conclusion, with an increasing trend to perform lamellar surgery, sometimes it's difficult to ascertain the endothelial damage in stromal scars, especially if they're very, very posterior. And following dog, even though there's an improvement, you can get residual folds that limit the overall visual acuity. The ZA intraoperative OCT guided femtosecond laser allows customized depth of this vertical trifine. This is using the liquid applanator, so you don't get any distortion on the corneal surface like you see with the flap applanators where you get those posterior folds. This allows you to do an accurate, basically vertical cut. The challenge is slightly, obviously, placing the DMEK basically in the gap, but you can see from the results in our paper you'll see very soon, you can get good functional recovery achievable with using this procedure. Thank you for your attention.